Table. So next we have Dr. Shweta. She'll be talking about scanning laser ophthalmoscopic capturing of the fundus architect. Shweta, please.
Yes, sir. My slides are not visible. Yes. A very good morning to all. Thank you, Satyan sir, for giving me an opportunity of having me a part of this discussion. And thank you, AIOS, for having me here. So my topic would be capturing the fundus through scanning laser ophthalmoscopy in a much redefined structural matrix showcasing. So if we talk about this, let's talk about the glaucomatous optic neuropathy first, which basically it's a ganglion cell death induced change in the structural manifested by RNFL, which eventually leads to visual field loss, which is manifested functionally. So the core concept of glaucoma lies basically into correlation in structural and the functional changes if we join all the pieces together. And if we want to embark the constellation of glaucoma diagnostic armamentarium, that's a precise constellation making, we all know that the existing visual field changes, they do occur when there are 30 to 40% of RNFL damage. But what if we can design something which clinches the diagnosis morphologically and morphometrically at an early stage, that is something bridging between the already existing one and which we are looking forward to make a perfect constellation of diagnosis. So having said that, what will be the missing piece in the puzzle? It comes as an early diagnosis. And the minute we talk about early diagnosis, the first thing comes in our mind is an red-free fundus photography. But the only limitation of this being a hypopigmented fundus or a myopic fundus, where the reflectance is not so good because the reflection is high and the contrast is low. Then what next? If we go back and look there, the milestones which were there in the field of early diagnosis of glaucoma before the visual field could manifest anything was GDX or polarimetry technique, scanning laser ophthalmoscopy, in the form of HRT giving these parameters, or utilizing the birefringence property of the RNFL with a polarized beam. But having said that, they all had limitations in the form of they were not being used properly, or the results were not to our perfection when the media opacity was there in the form of diatric means. What does that mean? It means any aberrations, myotic pupils, optic nerve head abnormalities, and previous refractive surgery. Also, to overcome this, many changes in the OCTs were also done, which did have their own limitations, especially when it comes to the direction of the RNFL bundles or the reflectance of the RNFL when it is compared to the other layer of the retina itself. That means what? It means when the OCT has a limited applicability for the inter-individual comparisons. Then now, next what? Everything has a limitation. So next comes that the way to the structural matrix, that is redefining the structural matrix from stars to the eye. And this was the concept which came into the picture when the role of adaptive optics was introduced with the SLO. This technology basically utilizes the extraordinarily detailed images of the retina at a cellular level. And the two main parts of this machine would be wavefront sensor that measures the aberrations in the ocular optics, and second would be the spatial light modulator, which compensates for this aberration picked up by the wavefront sensor. So any SLO which is incorporated having all these two parts is definitely going to have an added advantage of redefining the structural matrix as said. Now the advantage of this being would be that it has got a higher axial and transverse resolution with a better contrast and gives us the changes at a much early stage. Pertaining to glaucoma itself, the advantage of this AOSLO would be, if we try to understand the reflectance, how the reflectance from the cytoskeleton of the ganglion cell is gone to the incident light rays, basically it's all about the reflectivity of the RNFL. And this change in the reflectivity is always followed by the thinning of the RNFL. Mind you, the change in the reflectivity is always followed by the thinning of the RNFL. That means before the thinning, this change can be picked up very well by the AIOSLO, which fills the gap in this imaging technology. So now, having said that, different literature supporting the same thing, and if we talk about the images which we have been talking so far, it says that if we see the upper picture, which has got a white box beneath it, if we enlarge that white box, the lower box beneath that shows that these are the hyper-reflective images which we are getting through the AIOSLO technique, which are not obtained through the red-free fundus photography or the AIOSLO free imaging technologies. So now, again, a study said that they did have an advantage of picking up the changes at an early stage and also in a much shorter time. So now coming to you and presenting to you two cases which are definitely from the literature, of course, that a female was observed from 2013 to 2015, and as we can see from the top picture, these are the expansion of the, I'm not getting the pointer. Doesn't matter. So the topmost picture, if you see that these are the expansion of the RNFL bundle narrowing. So when we started in 2013, the part was 272 millimicron, and it further expanded up to 325. We are talking about the narrowing. And with none of the changes were visible on the color photograph, fundus photograph. Only OCT showed the localized thinned out area. Again, coming to a different individual where we could see the expanded vertically AIOSLO images. Again, the thinning area, if you see those, if you see those area, these are the thinning which are increasing. And this is and when you see here in this color fundus photograph, the changes are only visible when it comes to the cupping. And in OCT, there is only localized thinning. So now when you talk about these, we come across a new concept of RNFL bundle narrowing. It's not about defects, it's about narrowing. Because the older model said that there is a defect, but the new AIOSLO technique, of course, said that the bundles were narrowed, but of course they were present in the areas which were said to be having defects by the red-free fundus photograph or the red-free SLO imaging technology. So now, having said that, again coming forward with one more study, this is the image of a normal individual. This is the image of an individual with moderate glaucoma, and this is the advanced glaucoma. You see that these are the missing gaps which are being picked up by the AIOSLO technique. And this study said that there should be, now this picking up of thinning or narrowing is always a subjective matter. So to gain it to an objective way, the study done by Chaudhary et al. Said that there should be a system gain which works as a novel indicator for the glaucomatous optic neuropathy. And at the cellular level, it does manifest and shows that there are alterations in the cytoskeleton. So this objective indicator is going to be more sensitive for the early stages of glaucoma, in contrast to the current gold standard of differential light sensitivity measured on a logarithmic scale. So we can say that these microstructural changes were definitely going to change the glaucoma diagnostic scenario, making it much more possible for us to keep an equilibrium between over-treatment or a underdiagnosis. Having said that, to uncover the tip of the iceberg, utilizing the AIOSLO in developing algorithm for early diagnosis, the question still persists there: can we uncover the iceberg beyond the tip? Thank you very much.